Okay, so Dr. Strange is taking the stage again. This time he's talking about Alpha-1 liver disease. Dr. Strange?
Thanks, Marlene. Welcome back, everybody. So I didn't get to my question and answers because I was too long-winded in the first session. So what we're going to do in the second session here is to spend about 15 minutes talking about the liver, but then open up for questions about lung and liver disease so we can answer all the questions from the first section that we didn't get to. Well, the liver's important. You know, the lungs are more important, obviously, from my perspective, because I'm a lung doctor, but livers are real important, too. You can't live without a liver. Liver is a big organ. I showed it to you on that CT scan. It sits right up under the lungs on the right-hand side of our body. If you punch down real hard with your fingers, everybody can feel your liver up underneath your rib cage up under there. It's about the size of a football. So it's a huge organ in there. Everybody sees it in the grocery store when they slice it up in little pieces. Yours looks exactly the same, and yet it's a big organ, and it's the factory that makes most of those proteins that we talked about in the first lecture, including alpha-1 antitrypsin. There are lots of other cells in our body that make little tiny amounts of alpha-1, but the liver makes the most of it. And it makes it through the individual cells that live inside of the liver. The liver is also a very important organ to understand because it's got some unusual blood flow characteristics to it that lead to the symptoms that let you know that you might have liver disease. The liver is supplied by two different blood vessels, one of which is a blood vessel that comes off of our main aorta, the main blood vessel that comes out of the heart and has a little tiny artery that goes and gives it some blood. But most of the blood actually comes through a big vein here called the portal vein. The portal vein drains all the blood from our intestines. And so if we think about what the liver does when we eat food and we have lots of bacteria in our intestines to digest the food, this portal vein actually collects all that, in some ways, dirty blood. It has lots of different bacterial products and stuff in it. And it actually goes through the liver. And when we think about the liver as the cleansing organism of our body that takes all of this blood through the portal vein, cleans it out, and then lets it go back up to the heart to pump out clean blood to the rest of our body. Now, what happens in alpha-1 is we get this disease called cirrhosis. Cirrhosis is just a big doctor's word for scar. Scar in the liver can take lots of forms. If we have 1 billion cells inside of a liver and we scar one or two, is anybody going to notice? No, you've got to scar a fair amount of the liver before we start having enough problems with the liver to either not be making enough proteins or we actually have problems getting the blood through the liver. And if we have a problem getting the blood through the liver, what happens is the liver can swell, and you get that feeling of fullness under there when you're exercising underneath that right side of your body. Or if we have enough scar and we're scarring off some of these blood vessels, then the pressures inside this portal vein go up. And when the pressures inside the portal vein go up, the blood has to go somewhere, so it goes down these other branches. And so one of those branches goes over to an organ called the spleen. It goes up to branches around the stomach, where all of our food comes down. And those extra blood vessels, and goes up to a group of blood vessels around our esophagus, the swallowing tube that puts food down into our stomach. And so if those blood vessels get more pressure, they get bigger. And sometimes our spleen will get bigger as a result. The spleen's a very interesting organ. It helps make our blood cells. And when the spleen gets swollen, it actually can trap some of our blood cells. So when we start looking at whether our liver's involved with alpha-1 or not, we do a few things. We want to be able to measure the chemicals that are coming out of the liver and see if you're making enough of them. The most important one of those is a chemical called albumin. We talked about albumin in the first lecture, the number one protein that the liver makes. And so if our albumin levels are starting to drop, maybe we don't have enough machinery in the liver, enough cells making the albumin to make that happen. When we look at the kids with liver disease, we see that they have problems with a chemical called bilirubin. Bilirubin is the chemical that comes inside this organ called the gallbladder. The gallbladder traps a chemical called bile. Bile is made of bilirubin. And we don't make, and the bilirubin squirts out into the intestines to help us digest food. And if we're not making enough or not letting enough bilirubin out of the liver, then it can get into our bloodstream, and so that's what people refer to as jaundice. Jaundice or yellow jaundice is this deal that happens in most babies, but what happens at about day 4 to up to a year is that some of the babies born with ZZ alpha-1 deficiency will have prolonged jaundice. Their bilirubin will not clear over a part of time. So bilirubin is one of those blood chemicals we like to follow over time and see if it stays elevated, particularly in the kids. There are also some of these livers in alpha-1 get some inflammation in them, but some don't. And inflammation we measure with some chemical tests called ALT and AST, which are part of our liver panel. And so when you get your doctor orders a liver panel, he's looking at your albumin, AST, ALT, and bilirubin to figure out if you got liver disease or not. And the problem in alpha-1 is that this is a really, really hard biochemical diagnosis to make. And so sometimes we will have to do a thing called a liver biopsy. A biopsy is where we numb up your skin and take a really long needle and go, hold your breath, and get a little piece of the liver to be able to figure out if you've got scar or not inside the liver to figure out if you've got cirrhosis or not. So those are the tests that we use, and the problem is that those tests we think diagnose accurately whether you've got any liver involvement with alpha-1 maybe about half the time. And we don't know really well the natural history of liver disease in alpha-1 deficiency. I'll show you what we do know here in just a minute. So the issue is, are we really accurately diagnosing alpha-1 or not, or do we need better studies to figure this part out? Because if we could figure it out and get the stuck alpha-1 inside the liver out into the bloodstream, maybe we would fix the whole disorder by just fixing the liver part, and now we wouldn't need augmentation therapy if we could get that alpha-1 out of the liver cells. The other thing I'd say about this is there are some other funny things that happen that show liver disease. Sometimes people will actually have bleeding in their stomach or in their esophagus from these veins that get dilated and full of pressure as the very first sign of their liver disease. The other thing that will sometimes happen is the spleen will get big and cause some pain, or a low drop in a cell called the platelets. We see low platelet counts as some of the first presentations of liver disease, even if all the liver tests were seemingly normal. So there's some funny things that happen. We don't know how often those happen. But this is an important picture to kind of lock into your mind about what we're looking for when we're trying to find liver disease. These are the individual liver cells. They've been stained for this purple stuff, which is the alpha-1 antitrypsin that has been made in a ZZ patient that can't fold into a tight little package to get out of the liver cell. So the liver cells get packed full of the alpha-1, and now they can't work quite right, and we don't understand why the extra packaging here leads to scar in some cells, but not others. Because over here is a cell that doesn't have any alpha-1 inside of it, and it's a very patchy sort of process why some cells get alpha-1 in the liver cells and some don't. And what then leads to scarring in the liver is really not well worked out. In the registry, we ask you to check the box if you have liver disease, or a doctor has told you that you had liver disease or not. And we have this group of kids that have liver disease, and they're a very unique group of individuals that we don't know enough about. Most of the liver disease that happens in childhood presents in that first year of life. So if you have kids that are normal at 1 or 2 years old, don't have prolonged jaundice, it's very, 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 very rare that you're ever going to have any problems with liver disease. And in fact, in that study from Sweden where they tracked everybody, all 127 kids with liver disease, they actually spent a lot of time looking at the liver disease. 2 of those kids died in the first year of life. Today, they would probably get liver transplants. To think about transplanting your kid before the age of 1 is a really emotional and heartbreaking sort of thing to have to talk about, but we have those individuals in the Alpha-1 community that we all should embrace. That piece here is that if you have abnormal liver tests, almost all the time they get normal. And notice that there's almost no liver disease reported in late teenage and early 20-year groups. And then we start getting, about the age of 50, this other peak of adult-onset liver disease that we all worry about in the adult population. Interestingly, most of it happens in the ZZ population, but notice there's some MZs and some SZs that are presenting with cirrhosis. And we really don't understand this piece very well because when we say, well, MZ is just a carrier, nothing to worry about, these are your family members, and we realize that there's this little signal of liver disease happening with excess frequency in those carriers of one Z gene that might be in your family. And then we try and figure out what else added to a copy of the Z gene might make a difference why some of these people have liver disease and the majority of people don't. And so when we went through the registry and looked out who had gotten or was or needed a transplant, we found that those individuals that had no transplant need actually were drinking a little bit more and had a little bit more hepatitis virus out there. Compared to those who had moved and needed a transplant, we found more overweight individuals in this group. What does that mean? Well, we know that when we have obesity, and we all know that America is kind of gaining the weight across the spectrum of all society, is that we have this disease. It's got a big fancy doctor's name called non-alcoholic steatohepatitis. Steato is fat. Hepatitis is inflammation of the liver. We get fat in our livers as well as the rest of our body. And this fatty liver, when added to a ZZ gene, we think is the pathway where most people get liver disease. We can't get a signal. I can't get a signal in my registry out of extra drinking. We know that drinking causes cirrhosis. If you get enough liver disease, we're not going to say go out there and drink some more. But we don't think it's necessarily viral hepatitis or alcohol with alpha-1 genes that makes the liver be bad in some people. But we do think that weight makes a difference. That's why it's important to keep our weights as normal as they can be to prevent liver disease from happening. In children, we see that 75% of kids that carry 2Z genes are going to have abnormal blood test, ALT. About 10 to 15%, 1 in 10 patients will have prolonged jaundice. That's that yellowness of the skin that usually persists out to about a year. We don't really know the signal of if you get this piece of having a yellow skin and that's prolonged in infancy, how many of those people will develop scarring in the liver that lasts lifelong, or whether if you had childhood disease, that means you're going to have adult onset liver disease. But that's what our Swedish group of people are going to tell us in about another 20 years. And so that's the value of keeping up with these guys over time and seeing what happens as far as liver disease. And we know that liver tests usually normalize in teenage years. So what happens if you're a never smoker and you're living the good life with your ZZ deficiency? We don't really know what makes people die, but our best guesses come from 3 studies that have looked at death and what happens in never smokers with Alpha-1. And if you look at the numbers, they're small. That's a study of 21 people, not a study of 16 people. We don't have a lot of data about what gets people in the end. But we think that it's driven, even in never smokers, by emphysema, and about half the time, but cirrhosis, scarring of the liver, about a quarter of the time, although this study had no deaths from liver disease over the long time that they followed these individuals in Copenhagen. So that's the data that we have. We really need more data. The other interesting piece here is that a thing called the polymer. When we have Z protein going around our bloodstream, it's actually very sticky. And it sticks to other Z polymers, and the next Z polymer comes along and grabs, and we make these long chains of Z polymer that circulate in our bloodstream and stick inside those globules inside the liver. So if we turn up our electron microscopes really, really strong, we can actually see these little polymers of Z, chains of Z protein inside the liver cells. And we know that these make inflammation happen. And so there's a whole story and some really cool medicines coming down to prevent Z polymerization, wondering if that's going to fix the liver disease that happens and might be a cure for liver disease. So we've talked a little bit about testing for liver disease, but we're looking at your liver enzymes. The liver makes all of our clotting factors, so if your liver gets sick, you bleed more easily, so you start having nosebleeds all the time. Better go get your liver checked out. We're looking at low white blood cell counts, low platelets as a marker for liver disease, and a buildup of this chemical called bilirubin that produces jaundice. On physical exam, you might turn yellow. You have some funny blood vessel patterns on the skin. They're called telangiectasias. We can get swelling from the abdomen and the ankles if that blood can't get through that portal vein going through the liver. And you can actually feel your liver below that rib edge get bigger and bigger. These livers in Alpha-1 get big because of all that protein stuck inside the liver cells. We can see some of this on an ultrasound, a sound wave test of the liver. But it's really not very well picked up on a CT scan like we showed for the lungs of whether they're scarring the liver or not. And then liver biopsy is our gold standard test. We really need to know. We need to take a piece of your liver, and yet we don't do that for everybody in the Alpha-1 population in the absence of symptoms or something else going on. So the reason we don't do more liver biopsies is right this minute we don't have any medicines that are specific to get Alpha-1 out of the liver. We think those are coming. There's actually one study in clinicaltrials.gov. This is the government's website where you list all the research studies being done in liver disease. And there's one using a medicine called carbamazepine. Carbamazepine is also known as a brand name of a drug called Tegretol. And what this drug does, it's been around for about 20 years, it's a seizure medicine. And this medicine in the mice can get Alpha-1 out of the liver cells where it's stuck. It actually can do it in human cell cultures as well. And so we are hopeful that we have some medicines coming. There's some other medicines that do this as well, but the medicines have side effects. So just to give them out willy-nilly without being thoughtful and doing the research trials, we think is the wrong thing to do. Medicine called cyclosporin will fix this, but it's a transplant medicine that suppresses our immune system. A medicine called rapamycin will fix some of these conglomerations of the Alpha-1 protein. So we don't have medicines yet, and so right now our best medicine is transplantation if you get that far. We do symptom relief by fixing some of the things like the bleeding problems and fixing the edema if we have to. But this is a very difficult group of diseases to deal with when liver disease gets advanced. So in summary, I think that I should screen for liver disease after the age of 50. You saw where that second peak comes up for adults. For kids, there's been this discussion of whether we should add Alpha-1 to that heel stick baby's first test or not to figure out who has Alpha-1, who doesn't. Even though it's a rare disease in that childhood population, we'd probably be a lot more aggressive at treating the liver disease of infancy if we knew who had it and who didn't at day one, rather than letting their jaundice run for 2 weeks or a month before trying to figure it out. If we can figure out how to fix liver disease, we might also fix lung disease. That'd be the coolest thing ever. And this natural history of liver disease study will be starting soon is my last point here, and that came out in the Alpha-1 magazine, where Dr. Techman out of St. Louis and has two other centers that they're going to try and find 1,000 individuals to follow for 5 years to figure out who has liver disease, abnormal lab tests and abnormal tests, and who doesn't. And they're going to invite, of that 1,000, 100 people to say, yes, I want a liver biopsy. So you don't have to be in the 100, but recognize those are the kinds of studies that people really need to know to figure out the natural history of liver disease that we don't know enough about in alpha-1 antitrypsin deficiency. So I'm going to stop right there, and let's take questions until my time is up. And so we've got 20 minutes of questions, and I'll repeat the questions as we go on either lung or liver disease.
This one's on liver. If I understood you correctly, you said that when cirrhosis is present, the scarring is not uniform. It is sporadic around the liver.
Correct?
If so, how do you know the biopsy is accurate?
Yeah, that's a great question. So everybody heard the question. If you do a liver biopsy, what we get is a little tiny core of tissue. So like when they drill for oil, you see they go down 5 miles into the earth and they come up with these core tissues, which are just the layers of sediment that you get out of the drill for oil. We're drilling into your liver and getting a little tunnel of tissue. And they'll take multiple slices through that little tunnel to figure out if there's scar, and if so, in how much of that biopsy. If we know that we've got lots and lots of liver cells there, they actually grade the degree of scarring, the degree of fibrosis is the doctor's word, on how many of those slices actually see any scar in. Our liver, all of us have a little bit of a chemical called collagen that helps hold that liver together, and scar is just more collagen. So they know it's normal, and they'll be able to see in that group, and they're pretty accurate because the core of tissue is actually a lot of cells, and they think they get a pretty good representation. In the studies that have been done after somebody gets a liver transplant, for instance, they can look at the whole liver. They're always 99% accurate on a liver biopsy about how much scar you have. So that's Laura and then Pam. So question.
Oh, is the MRI a good way to detect liver disease?
Yeah, this is a great question. So magnetic resonance imaging is kind of like a CT scanner where you go through a big donut, except instead of using X-ray beams to go through your body, they actually use electron spin, and it gives us really, really pretty pictures of our knees and of the anatomy. And the question is whether it gives us a pretty enough picture of our liver or not. And I think that I'm not convinced yet that the MRI all by itself is going to be the magic that tells who has scar and who doesn't. And I think in this natural history study, they're probably doing some MRIs and try and correlate them with who has scar and who doesn't. The cool thing about MRIs is you can actually put in extra chemicals into your body whose electrons spin different ways. And so we have a whole MRI research team looking at ways to diagnose Alzheimer's really early and those kind of things by putting in a chemical that will then light up different funny chemicals in the brain. And so this whole process has not yet been turned to the liver, but I think you're right that over the next 10 years we will have a diagnostic liver test that will not require a liver biopsy. And it might be through the MRI is the way to do that. But it's an expensive test, and we'll see how that goes.
Charlie, this question is one that I saw in the chat room, so I'm speaking for people that aren't here, but I'm thinking perhaps other people in the room have the same question. The over-the-counter products that are out there that people take to supplement what doctors prescribe, particularly Tylenol, has liver implications. And then in the mucus removal meds, you run across so many that have alcohol in them. Can you give us any general, is Tylenol something to stay away from, and do we need to be reading the over-the-counter products more carefully when there's liver implications?
Yeah, that's a great question. So Dr. Techman, who I just mentioned earlier, actually has a human liver cell culture with Z genes in it. So he's got some liver cells living there in his little culture dishes, and he can give all kinds of chemicals to them and figure out what does good. He took the study and added aspirin to his cell cultures and added Tylenol to his cell cultures to see which one hurt his cells the most. It was actually aspirin that hurt them a whole lot more than Tylenol. And whenever we have aspirin, we're also talking about other non-steroidal anti-inflammatory drugs. That's ibuprofen in any form, Motrin and naproxen, Aleve over the counter. And so we actually think that those medicines that we all take for aches and pains and occasional headache are actually a little bit more hurtful to our liver than acetaminophen, which is Tylenol is in lots of its forms. We do know that Tylenol in big doses sometimes kills a whole liver, and I see those people in my intensive care unit that come in with Tylenol overdoses. But if you're, according to the package insert, staying within the limits of Tylenol, we actually think it's a little bit safer medicine than the aspirin and non-steroidal drugs like ibuprofen for aches and pains that we take. Moderation is the key to everything in life. On the lung side, we have lots of different opportunities out there, and as y'all know, the National Institute of Health actually put up a whole institute to study alternative medicine in all of its different forms. So they're doing trials in acupuncture, and they're doing trials in vitamin C, and all this sort of other stuff that is available over the counter. They have sponsored more than 500 trials in alternative medicines, doing randomized trials where they flip a coin and give patients placebo or the over-the-counter medicine. They have come up with about 3 positive trials that actually make a difference that they can measure. Can't say that they aren't beneficial, but most of the positive hits in their research trials have been with vitamin D. Vitamin D helps fight inflammation and infection in our body. Debunk the whole vitamin C story. All of the studies thus far with other antioxidants have all been negative, but there's a whole robust part of this research agenda looking at these medicines and whether everybody's wasting that $3 billion a year that are spent on over-the-counter medications or not. And so I'm not averse to anybody trying them if you want to. It's your money. But boy, I'm all about evidence-based medicine and trying to use the medicines that we prove make a difference for almost every condition that I see. All right here, and then we'll go back into the back.
You mentioned 3 and then only said 1. What are the others?
And there are actually 3 different vitamin D stores. And I don't keep, I guess, in fairness, I don't keep up with every study going through that whole institute. Yeah. Okay. The question was, what were the other 3 studies? And I can't tell you the honest answer to that one. So, and we're going to the back and then to up front.
2-part question. The 81 milligram aspirin that a lot of doctors prescribe for some reason, is that on the issue also?
Yeah, so that's a great question. There's a very large study in Europe that was done looking at a 5-year study of COPD that was not Alpha-1 related. They had the idea that if you took an inhaled bronchodilator and inhaled steroid for 5 years, you could actually improve the number of exacerbations that happen each year. Exacerbations, a big doctor's word that means more mucus and more wheezing that needs an antibiotic and or a steroid medicine. And indeed, while they looked and saw less exacerbations over time, they were really focused on whether they could save lives by taking medicines every day for your lungs compared to just taking them when you need them or not. And what they found in this 5-year study where they thought they were going to see lots of pneumonia and people end up on ventilators and death due to lung disease, with the number 1 cause of death in COPD is due to heart attacks. What does that mean? We don't even need to talk about lungs. Let's talk about our hearts here for a while. If your number one cause is heart attacks kill about 3 times more people in the United States than anything related to COPD every year. And we know that aspirin once a day, small dose, 81 milligrams is the baby aspirin, is actually one of our cardioprotective medications along with others. So it means if you start getting all this chest tightness and you think it's just your lungs futzing out, then what's the right answer? Yeah, we go get a stress test. We think about our heart health and eat healthy and that sort of thing. So it's just a very strong cardiovascular message that is the reason that we still recommend 81 milligrams of aspirin for everybody with COPD. And the second part of your question?
Second part of the question is diet restrictions.
Yeah, we think that weight is a very important part of keeping COPD health ongoing. And we know that when people start losing weight, it's a very bad sign. That actually being a little bit overweight is actually better than being underweight when you have COPD. It means when you do get sick, you've got a little bit of body stores to be able to weather the storm of some severe illness. So we don't like seeing people lose weight and get too skinny with their COPD. And then,
is the incidence of heart disease elevated in Alpha-1?
we have not studied that in Alpha-1. We're actually studying it right now in our ACT study questionnaire about have you had heart disease, and if so, what kind? Do you have heart failure? Have you had a heart attack? Those sorts of things. So we ought to sort that piece out, I think. But those studies have really been done in COPD. And the incidence of COPD, let me rephrase the question. If you smoke for 20 years, and we know that smoking causes heart attacks, then if we took 100 people that had COPD plus the same amount of smoking and compared them to the people that had smoked just as much but didn't have COPD, the group with COPD has about twice the number of heart attacks as the group that have never had any COPD abnormalities. So we do think that COPD adds to the heart attack risk. It's never been studied in Alpha-1 specific COPD.
Another question: if you're on long-term use of NSAIDs, should you be monitoring your level of your liver function?
Yeah, so this is a good question about the practical application of what we showed about all the tests that we could do. And then the next question is, what should we do? And what I recommend is, based upon no data at all, is once a year to go ahead and check your liver panel if you're over the age of 50. There's a new guideline getting ready to come out from the liver disease specialists, and we know that in the background of liver disease and cirrhosis is that scar in any part of our body slightly increases the risk of cancer. And that's regardless of what organ in our body gets a scar. And inside the liver, in this cirrhosis patient, it's about 2 or 3% of people that live with cirrhosis that end up with a liver cancer. And a liver cancer can be cured if you cut it out, but you have to cut it out at a small stage. So, since liver cancers can be diagnosed by that sound wave test called the ultrasound, this recommendation that's getting ready to come out is going to suggest that you get an ultrasound twice a year to find out if you got a liver cancer or not. But we know that's a very, very rare finding in Alpha-1 liver disease, and now we're trying to screen everybody with twice-a-year ultrasounds to find something that's pretty rare, and whether we all want to do that or not, and it's never been tested before prospectively, becomes part of the issue of whether we break Medicare's piggy bank even more than we've already broken it or not. So I just recognize that recommendation's out there. I personally have not started doing that yet. I come in once a year looking for the blood tests that are associated with liver disease, and in people that have abnormalities, following them more closely than that. There's a question up here front.
While you were talking, something clicked through my head. Is there any relationship between Alpha-1 and epilepsy? Has that been looked at all?
Not that we know about. Yeah, go ahead. Jonathan, you can make the choices from here on out.
Okay.
Since Alpha-1 is an anti-inflammatory chemical that we're deficient in, does that lead us to have more joint pain, muscle pain? So do we have more inflammation in those areas? Because I know I do.
Yeah. One of our most common questions is, Dr. Strange, I have this funny pain on my earlobe. Is that related to Alpha-1 or not? And boy, it's really hard to sort those kind of questions out, because to answer any of those kind of questions, we really need some pretty big epidemiologic studies. We just go through the registry and say, anybody with earlobe pain, tell us if you got it or not. And now 5 people come in and say, yeah, I've got earlobe pain. It doesn't mean that is necessarily associated without looking at all the other people. So trying to figure out and having adequate numbers of control groups is part of our research, and looking at these other comorbidities about whether there is extra arthritis, whether there's extra fibromyalgia, aches and pains in our muscles or not. And these are kind of the hot topics where we think there might be a signal there, but we don't have any good data that really says for sure that that's what happens. We know that when you get inflamed lungs, lots of inflammation goes through our whole body, and so a lot of times we cure lung disease and magically all the aches and pains go away. We get people sleeping better at night, now all the muscle pains go away. And so the piece of how important the lungs are is really the piece that needs some further work.
I don't think I've ever asked you this question before, but what's the regular size of a normal liver, a typical normal liver, compared to a Alpha-1 liver, say stage 2 cirrhosis? Or, I don't know, you can use any range since it is a lot larger.
So the liver size is not a very good measure of how much liver disease people have, because what happens as we start accumulating Alpha-1 protein is that the liver will get to be an NFL-sized football, and then as scar starts happening, it starts shrinking again. You scar away a few of the liver cells, and now you've got a peewee football as your liver. So it's one of these things where it starts normal, gets big, and then it gets small again. And so liver size is really not as sensitive as our blood tests and our biopsies and our ultrasounds to kind of sort out some of that. But we do have some people that kind of get some pain when liver gets enlarged.
I was just wondering what your thoughts are, like a couple of glasses of wine at night. How does that affect the A1As? I mean,
Yep.
Is it bad?
So this is a very important question for the community. You notice they served wine last night to dinner, didn't they? Can't be too bad, but I think what you'll find is that there is probably more difference of opinion in the Alpha-1 community around this question than any other part of the what do we put in our bodies sort of question. And my take comes from the data that we ran out of the registry that showed that the people that drank moderate amounts of alcohol actually went to transplant less than the people that were actually teetotalers. The teetotalers, you'd be amazed how many of those 25 people out of the registry that went to transplant had never, as in the questionnaire, no, I've never touched a drop of alcohol in my entire life. And so, I question these guys with the cell cultures, is it possible that alcohol helps Alpha-1 get out of the liver cell or not? And they say, no, that can't happen. And yet this is the reason we need this 1,000-person natural history study to kind of sort things out, because 25 patients does not make a true statement on the liver and alcohol use. I would say that once you get to the point where you have symptomatic liver disease, you should stop drinking. And I think that message is pretty clear. All your liver doctors are going to say that, and I'm not going to go against their say-so on that one.
If you have, like, the MZ gene, and you get hepatitis C, B, and all that kind of stuff, can it trigger the reaction within, with the Z gene to cause liver damage in the future?
Great question. And if we look at how many MZs are out there, then we think that there are about 10 million MZs that live in America. We don't have 10 million livers falling off the face of the earth here with liver disease. So there's something unique that triggers liver disease in an MZ population that we don't understand fully. We're not so convinced that it's hepatitis virus. We wonder if it can be occupational. We do see liver disease in MZs running through families that have a ZZ with liver disease. We think there may be other genes besides the Z gene that kind of make one member of your family with liver disease impart some of that risk to the MZs and other family members. We're not convinced it's alcohol. We do think there's that signal around being overweight, but I'm not convinced that it's virus that adds that extra burden, but it's something that's out there. And so this is where that natural history study really, really helps.
Has there been a connection determined between thrombocyclopenic purpura, drop in platelets, and Alpha-1?
Okay, so there is a disease called ITP, idiopathic thrombocytopenic purpura. How these doctors come up with these names, I don't know. But ITP, let's go, idiopathic means just happens. We're not smart enough to figure it out. Thrombocytopenia is the big doctor's word for low platelets. Purpura is because we get little bruises when our platelets are low, and if you bump your hand and you get a little bit of bleeding under the skin, it actually turns into a purple mark rather than just being a little bruise there. So ITP is a disease related to low platelets that they think just happens. The disease is taken care of by a group of doctors called hematologists. These are doctors of the blood. So they see with anemia, low red blood cells, low white blood cells, low platelets all the time. They don't know anything about Alpha-1. And so when we see low platelet counts, boy, we think that there are a lot of undiagnosed patients out there with occult liver disease that's just beginning that end up actually having liver diseases that cause their low platelets. But what they do for ITP is they give people lots of pretty expensive treatments like plasmapheresis, spinning their blood through a pheresis machine. They give them medicines, sometimes high-dose steroids to try and bring the platelets up. And that doesn't mean that somebody in an Alpha-1 population couldn't have ITP. There are a lot of other diseases that are out there. So I never second-guess my hematologist, but I do make sure they're aware. Let's go look more carefully at the liver to make sure there's not liver disease as the cause of low platelets, rather than calling it idiopathic, just happening. And ITP is out there, and I can't tell you how many ITP patients I've seen that actually have Alpha-1 liver disease as the cause of their low platelet counts. Last question, or am I done? I'm done. Thank you all. It's been great.
Dr. Strange will be around throughout the day. You can ask all the questions you like, and it's great that he's so accessible to patients in this region. So we'll have